keep eating. I don't want to stop that part. I want you to not only get the nutrition as well, we're going to go through it quickly. But you don't know me, I'm Mark Adams. I'm the Health Commissioner for Lorain County Public Health. And today we're going to be talking about our community health assessment. And we're going to be talking about all the things that everybody can know each other. We're going to go who had experience with community health assessment. The basic things on what it means, the importance of the document itself, what does it mean going to the future. I'll try to give you an idea. There's not a lot of information, but it does give us a starting point of where to go from here and what can we do to fix it. The other thing is that it also, I'm going to talk about with this document when it comes to collaboration. So when you look at how the document was put together, all of the partners that are part of this, our community health improvement plan steering committee, as well as how this got paid for. Now, normally, we'll go through whether it's or we change that. What we have this year is 9 months of solid work. We need to make this a Lorain County document. We need to make it that's about Lorain, for Lorain, coming from Lorain. And that's what we did with it this year. And that's what makes it a little bit different. It's a lot of work, a lot of sweat into it, or something that we can build upon to make better. And the one thing that you see here with all the partners, with Cleveland Clinic Hospital, Lorain Health and Benefits, our Metro Park, Public Health Department, our Mental Health Addiction Recovery Service, Lorain County, Nursing Health Ireland, Nursing Health Lorain Hospital, Specialty Hospital in Lorain, University Hospital of Lorain Medical Center, and the funding itself was we combined the funding together to be able to do. Now, that's an important statement. This shows you who all got together to do that. That's it. It's nobody just doing it by itself. That's the nice part about it. And I'll talk about Lorain County a lot when I talk about the positive parts about Lorain County. One of it is the people need to get together. In this county, they do. And this is another but that's one thing that this county does. So, and to show that unity piece, we've got representatives from the hospital here to be able to agree, and so that way you see that they're here, and you see that the importance that they have of this, the whole process and the document itself. So first, I want to bring up Todd Harper, president of University Hospitals in the area. He was interim in 2021 and became president in December of 2021 with 27 years of experience in University Hospital system. This microphone's live, or you can do this one if you'd like. Good morning, everyone.
You know, I'm pretty new to this community, but the one thing that I realized very quickly is the collaboration that goes on around the county. Very impressive. And this community health assessment is a major component of our community benefit program, and we're very happy to be a part of it. You know, we listen to the community. We want to understand what their needs are, and with the help of Mark and his team, who does an excellent job, we try to help the community together and make our community better. And I'm very happy to be a part of that. So as we move forward, we have a plan for the next 3 years. You're going to see what we've been doing. Hopefully you'll agree that together as a team, as you saw from the slide, that you agree we're meeting the needs of the community. And if you don't, and we're just happy to be part of it. And I appreciate you and your team. You're keeping us in line, you're keeping us motivated, and you're keeping us on track. So thank you to you and your team for everything. Thank you.
Next, we have Dr. Stark. Dr. Stark has been practicing in the Avon area since 2005. In 2010, since 2010, she was the chair of the Cleveland Clinic's regional OBGYN department and became the president of the Cleveland Clinic Avon Hospital in 2014. Dr. Stark?
I'm going to try this without a mic. Is that okay? Can you hear me? I'm not really a microphone person. So first of all, I want to say thank you to all of you leaders for leading your teams and the individuals that you serve in our community. The last 2.5 years have been unprecedented. We've all heard that word. And I first sat in this room in 2015 when we did our community health assessment at that time. We had another one in 2019. And what I will tell you is the state asked us by 2020 to get together as counties and hospital systems to align our community health needs assessment. We have done that in Lorain County. You can see the collaboration. It is true. We are all working together. We know that health outcomes are really only 80% or 20% attributed to health care. The rest is attributed to those social determinants of health: food insecurity, housing, transportation, education, economic impact. All of you are the biggest impact on our health outcomes in our community. We as health care providers are doing everything we can, but we can only touch the lives of those individuals who come into our facilities. So we try to provide outreach into the community. We're doing that in various areas with free health screenings, et cetera. But it's really the work that you're doing, and we see so many phenomenal leaders down here, the Mental Health Board, and Second Harvest, and I know El Centro. We all have to continue to work together to touch the lives of the most vulnerable around us. Our infants, our children, kindergarten readiness, the children who have suffered through the pandemic. You know, they've lost some years in their educational process. We have to understand how to better help them. I can't imagine what it was like to be a teacher during these last 2.5 years, to pivot and figure out how to teach through online learning. I couldn't do it. So I applaud all the efforts, and I know we're going to continue to work together moving forward. I think that Lorain County has a lot to be proud of, and I'm confident that if we continue to collaborate and continue to work together, we will emerge stronger through this. So I just want to give my support and my thanks, and together we will achieve great outcomes. Thank you.
Representing Mercy Health Lorain, Vice President of Nursing since March of 2022, previously the Director of Nursing Services and Nursing Director of Medical and Surgical Oncology and COVID Unit, with over 16 years of experience at Mercy Health, Millie Castillo. You want a microphone? You got it.
Yeah, I got strong arm to come to the microphone, guys. So I just really want to start off by saying how honored I am to be here. This is the third time that I've had an opportunity to be here on behalf of Mercy Health. And one of the things that you heard Todd talk about, and you also heard Dr. Stark echo, is that collaboration. And that's what's wonderful about coming together for this community health assessment, is that opportunity to really collaborate together as a community. You know, working for Mercy Health, I've been with the organization for 16 years, and one of our strongest emphasis is really extending that healing ministry to those that are poor and underserved in our communities. And working for Mercy allows us to do that, but coming together as a collaborative team and really looking at the needs of our community, and you know, being a part of this for the last 8 years has been tremendous. So I am truly humbled. I am truly honored. You know, you heard Dr. Stark talk about all of the different individuals and areas that have had an opportunity to give some feedback. And what we're looking for with this team is to really continue to help us to collaborate. This plan allows us to hear the voice of those that are underrepresented in our community. And it is our role to decide what we do with that. What do we do with that information? So we're going to hear a lot of information being shared today. I thank you for being a part of this. I am humbled and honored to be a part of this. And I'm just looking forward to the work. So thank you.
All right. So some of you know me. those that, I was talking with talk about assessment. That's when you know this problem with that process. It does, and it does not. But one thing you're going to get from it, because for me, by the age of 4, my mom and I. By the age of 17, my brother was still apart. 5 years ago, my brother was it's not. And no way. But like we look at it, like 3 years and 6 years. Unacceptable. I don't know the way they are. So it's not just a document. But everything is announced. And I really want to hear 4 years of service. Now, when I went to service, because by the time I was now, my nothing but protect. And that's what I wanted to do. So we need to know so we're going to talk about the purpose of adoption. And we'll get to it because it's really information. But it's not because we're all in mind. We're going to talk about data methodology pilots because when I'm having people do it, highlights in the and we're going to get not the best information, but it's called out to do make those instructions better. And then we're all back. What do we plan on doing from this? So the community health needs assessment and the community health assessment. Legally required. As of 2016, laws came out and said the health department shall do. Now, some health departments so it's not new science. It's something that started a long time ago. Some got onto it, and some people did not. Well, as of 2015, we're required to with the Affordable Care Act, that's going to make it all that nonprofit. What is it? It's data driven. Primary and secondary data put together into a snapshot, a long-term snapshot of what goes on. And it's data. It's not blanket. It's not anything like that. It represents what's really happening. It's transparent. It belongs to you. It belongs to everybody. It belongs to all the 10,000 people here. It belongs to everybody outside of this town. There are really local. If I have anybody that would ask me, then there is a order. We are the one in account. Anything that and all that collaboration. you have no collaboration, if you're not working together, it's document will die. You will absolutely die, nothing will happen. The only way that this becomes a living document is you talk about it and you spread every bit of information everybody needs to do, not just us. The child self-identifies key health needs, issues through systematic, comprehensive data collection and analysis. Go and grab that data, we pull it in, and you put it together and say, this is what collection is best when gathered through proactive, broad, and diverse means. That's why we have a way that was just a questionnaire. So we try to grab multifaceted situations. That's the way to a living document. The data and transparency make it a starting point for the shift. So this is the child. This is where the information. That's what we need help improve. So that is after we get this information, then we need to get together and say, what do we do next? If that's the shift. So with that, the previous level of D5 actually do the same for this one as well. Right? They're going to be declining maternal and child health. Right? Which is why here is it's number one killer. You think it would be on everybody's but it is an art. So, I want to start with I want to go over that just for you a little bit longer as well. If we have areas in our community that have that do not recognize that the jobs are present, we can spend a lot of time jobs are out. People need to go see them. But we also then have to be able to provide education for them to go to all friends. Very much not just building the building, making sure that people can't watch the after go who build it. It's not the way it works. Things don't get perfect. Neighborhood and build environment. What happens with our I mean, if the dumb stuff can't go, we always see the way we work. People from the industry out, people from the industry, and they start to work, and we don't have and we think, but that's not the way. It's not affecting healthcare, that is not affecting the cost of medical education, not affecting the cost of social and community contact. So there was a study communities that have and one of the things that existed in each of those communities, that they had social community contact, that they were part of the community, that they felt part of the community. They had to be present. So when I was 2011, I had to be present. And public grants have been called. Everybody should have the exact so we start with the actual this is the difference for people when the request for going through 211. So in 2020, this is kind of giving you an idea of what I'm saying to you, I need the number one was reticence, tax preparation, COVID-19 vaccine, electric, food food. Maybe none of this is but we have a little people that are. And then in 2021, we saw food in another first world country. We have people. It is possible that anybody from the food bank that can get food whenever I hear It's so difficult. Rent assistance, tax prep again, electric and appliances. We have the ability to do this, but not everything is left. A lot of it is specific on any expenses, because we live wherever we be, we're not moving. Mitch is going to come up and mention the COVID. This is the COVID. So if you look at 2020, it's not going to be people going over. But we did have more left. Not only that we passed away, before we get specifically in each piece of the data, what is that? Mitch Dandurand is coming up. Guru. And he's not. Okay.
Hi, everyone. I'm just going to go over how the methodology has kind of changed for our community health assessment. In previous versions, it was what Mark was saying, a community-wide, I can't get any closer, a community-wide survey. Is this better? Is this better? Okay. It was a community-wide survey that was very broad, very wide-ranging. For example, if we got results that said 20% of the county delayed healthcare due to high costs, while that was an important question to answer, getting it to an actionable data point was difficult. So is that more prevalent in the south of the county? Does it vary by age group? Does it vary by health condition? Very difficult to understand that if you don't have enough people taking the survey. It's an impossible question to answer. So using secondary data, that is data that is collected through healthcare facilities and governmental institutions as a part of their record keeping, we are able to not only have more observations, but allowing us to dig down into those subpopulations, and the margin for error is much lower. So what this version of the health assessment has to offer is that secondary data analysis that we're hoping would drive the primary data collection in the future as this evolves. So not saying that surveys are not important, they most certainly are. But the strategy here is to use secondary data to have a more targeted approach, meaning asking the right population the right questions. So I don't want to turn this into a college lecture or anything, but just how everything is formatted. We're using, again, secondary data to estimate the burden of each health condition on the community. Incidence rates, prevalence rates, mortality rates, and then trying to answer that question of why we are where we are using different measures of association. So trying to not only identify different determinants of the health outcome, but quantifying them. Which factors play more of a role than other factors? That way we can find those populations, we can ask them questions around what might be determining their health. And then looking at everything over time, obviously, is very important. Where were we 10 years ago? Where are we now? It can give a good perspective on where we might be in the future. So you'll notice a theme with each health topic. Where are we as a county and which direction are we heading? allows you to set goals, set priorities, and then identifying target populations or priority populations, who is most at risk. So who is most at risk, that's basically broken down by race and ethnicity and income level. Not necessarily that those things cause the health outcome, but they act as a proxy to identify a variable that is directly related. So for example, if low income does not cause heart disease, being low income affects quality of diet, stress levels that are directly related to cardiovascular health. Which leads me into the next bullet point, which lifestyle or behavioral factors are closely related to the outcome. Again, not only identifying, but measuring it, quantifying it. These CHIP groups can use this information as a jumping off point. Which variables should we be looking at in our programs? What should we be surveilling? Who should we be targeting? So this is going to be a little bit of an oversimplification, but I want to go through a practical example of how you could approach the health topic within the health assessment. So looking at county preterm birth rates, clearly it's looking at the 5-year trend line, that orange line there. It's going the wrong direction. It shows us where we are currently. This is a percentage of all live births. Where are we currently? 10.4, and which direction are we heading? This again allows groups that are working toward this to set realistic goals. So at this stage, you would almost say a leveling off could be considered a success, looking at a 5-year average. And then getting into who is most at risk. So over time, it looks like each demographic has increased their preterm birth rates. So that's not unique according to demographic. However, clearly, non-Hispanic Black mothers are more at risk, disproportionately affected. And then furthermore, you look at the extremely preterm, very preterm, non-Hispanic Black mothers are way overrepresented in those extremely preterm, very preterm categories. Given that extreme prematurity is the number one cause of infant mortality in the county, that would be a very relevant data point to start building some knowledge on the topic. And then leading into those health characteristics that directly affect the outcome. So looking at preterm birth, having a previous preterm birth, you're over 3 times the risk of having another one. Inadequate prenatal care, you're over 3 times the risk of having having preterm birth. Pre-pregnancy diabetes, pre-pregnancy hypertension, very closely related to preterm birth. So while this doesn't give you the complete picture, far from it, it's a good starting off point of what variables should we be looking at as a group to either start asking the right questions about the population we're looking at, and also what variables should we be looking at when we are doing our surveillance, when we are doing our programming, so that we can measure our success much easier. So just briefly, what you can kind of get out of this is realistic goal setting, information for program planning and policy development. And then a big key, I think, is the more targeted approach on that first-hand data gathering. Again, we used to do those big, broad surveys for the whole county. How can we find the right population, and what questions should we be asking so it can produce an actionable data point? And then grant proposals. This is a document that's going to evolve. So we encourage anyone that is writing grants to, if they are looking at a particular section and have want to get a more deeper answer or more context behind something, just request it, and we'll see if we have access to that, and we can try to add that to the living document that is the health assessment. So Using all of this information just broadens our understanding of the health topic, rather than just kind of taking a shot in the dark based on a data point that is community-wide. So that is all I have.
Okay, so some of the things you know, 95 years when we go on the road, people were positive that a sign get people until they figure, hey, this is not keeping somebody drinking or somebody falls asleep from outside the road. We did a study later and that we can do something audible physically that would jar them wake them up. They really drive. So some of the things that are happening. Well, we've been able to we have black men heart disease. When you look at stroke, 16% increase in deaths since 2015. Death rates are currently twice as high among non-Hispanic. Maternal and child health, infant mortality, 10 years of data. Overall infant mortality rate means change. So there's going to be an average mortality maintained. But disparities across racial demographics become even more evident. Infant mortality for Black babies is more than double. And when you look at the chart that's in there, you have white babies here, and white babies. There's a strong correlation of factors that impact outcomes and risks: healthcare access, economic stability, and social and community ties. Maternal and child health when it comes to ACEs and kindergarten readiness. Anybody know what ACEs? Oh, that's actually not a lot of people. ACEs is the child and they link those childhood trauma events to outcomes, to developmental outcomes, to where they're able to whatever they get. Suicide. 5-year average suicide rate has increased by 23% since 2015. In 2020, we had a suicide rate of 16 deaths per 100,000. We've exceeded that state average. Who's at risk? Males, significantly more likely to die by suicide, but we did see an improvement in reduced number of substance use, drug overdose deaths. Now, I remember seeing the ranking of something on that 3 nominees in a row, and they there were 7 overdoses. If there were 7 overdoses, we get a call from the state to pay exactly the fourth, but it was moving along on case on or something. So thank you for well, you're 5-year average drug overdose, it's doubled since 2015. The rate is higher among men and non-Hispanic white population, but the sharpest increase is in the non-Hispanic white. Cancer, some effects of COVID-19 are evident or could be evident. Newly diagnosed cases dropped by 8%. Does that mean right? People stop is now in stage 4 pancreatic cancer at about 16 waited. He was one of them that did not go. We had pain. He didn't have the procedure, the whip procedure. So he's one of those numbers, one of those statistics that did not go. But we did not. We did see some successes, early detection of some cancers have increased, but some of the failures of early detection of prostate and cervical cancers worsened over the past. What are people saying about speaking out about residents? Reaching out to everybody, reaching out to the neighbors, who they talk to. They gave these words, they mental health providers. They're looking at Black specialized doctors, having to leave the county for care, long wait times, translation service, somebody who can speak my language, travel far to provide a provider, burnout, that probably involving high school students, which is a great reminder. The future is back there in this room. This is going in front of everybody, every single younger than us needs. Because I mean, there's a saying when it comes to Ohio, and you find this sure you have insurance. It is that because Ohio is actually really good when it comes to time. Also, though, we are pulling from the top. Spending. All right, so they're looking, they're saying trouble hiring and cultural competency. But we have some success. There are some. We have Project Dash getting food to seniors. Child Care Resource Center working with Child Care Education Centers to pass healthy policies focused on that family engagement. We have partners offering suicide prevention, QPR training, and have staff that are able to offer that training. So we have trained staff in the department as well as all throughout the county to be able to do that. All public schools passed 100% tobacco-free policy. And there's a future helping provide that. Multiple partners offer Narcan rescue kitchen training. We can still do better. We can get that Narcan. All right. We have other things, great things that happen. We are a county first. We're a county that has a college, the first college to offer African American and women the first grant of right to college education in Epidemiology. We have access to a college education. It's the first permanent college, community college in Ohio. Here. The first high school west of the Alleghenies. Children in Lorain County first to be offered COVID-19 vaccine in Ohio. Got a voice in federal government. Not every county can do this. Some counties that might have but that one there might be people there. You hear people here, we have a place, and they will live with it. We have the team. No, there's actually not a we have the team. We have the businesses that work together. We have healthcare. Yeah, I'm not sure if there's another healthcare system with 3 hospitals out there that have community power. It's all Epic now, right? Well, yeah, but close. Yeah, that's closer than anywhere else. That's like, that I've heard it. But not everybody has this history. We have community organizations. We don't have a shortage. We don't have a shortage of people that are out in the community working with each other. We don't lack in those services. We have mentors. We have teachers. We have our teachers. We have everybody else that works. People that work with children. We have change parents. We have our children. We have and other groups that are like that. We have people that care about our kids. We have people that care about our patients. And then one thing we have. There's always going to be somebody that's like. But the vast majority of our future is here. We do have our future here. Not only in the term, we need more in the term, but we do have one. We can continue to do better in education. Industry. We have industry. So that's part of the social determinants of health that we have. We have industry. And then one of those problems we've done a lot of it. And then we have the neighborhood. And we have the so we might, if we see it from Lorain, they look at it and say, all right. Before I have Sarah come up with our so when I brought up it's not what we have everything, but I want to give you an example of how to look at these types of things and really and kind of start seeing it. Now, here's a picture of the evolution. I guess want to be a first aid. I remember 9 years in the field, 7 locations. And in a way, we have and that's with the board. So, what I'm going to bring up, Sarah, what do build Sarah?
Perfect. Okay, thanks, Mark. I'm the last speaker. I'm the last speaker before we'll open up the floor for questions. And I got the easiest section, of course, what happens next and where do we go from here? So now that we have our community health assessment, we have our data, it's time to work on to create the community health improvement plan, the TIP. And
For this next 3-year cycle, our 5 CHIP priorities are going to be the same. They're going to be chronic disease, substance use, maternal child health, cancer, and which one am I missing? Mental health. Thank you. So they're not going to be changing in any way for these next 3 years. But what we do need to change is how we craft our actual community health improvement plan. And there are some changes we want to make so that we are really taking more of a bottom-up approach, and we're relying heavily on the existing partner groups that are meeting all the time in this county. Been here for 7 years, and I think I've either facilitated or attended or, I don't know, visited a lot of community groups. And I know everyone here is going to community group meetings all the time. Those are the task forces, the work groups, the subcommittees, the collaboratives, the coalitions. And what we really want to do in this next cycle is how can we take the work that's already being done there, because these groups are doing the work of public health and they're doing the work of improving social determinants of health. And how can we use that existing work to really create the next CHIP? Instead of sitting in a meeting, creating the CHIP and pushing it downwards, let's use what's already going on, what's already working well to be the building blocks of the CHIP. So my call to action, the LCPH call to action is, coming out of COVID, meeting is hard. These partner groups are hard, and we're meeting virtually, in person, some awkward mixture of both. But we really want to reinvest and re-engage in our partner groups. We want to drive attendance and engagement at these groups, get involved in a collaborative or a coalition, and let's focus less on large meetings at the CHIP subcommittee level that, quite frankly, only meet 12 times in the CHIP cycle. So let's reinvest our time and our brain power at the local community groups, coming to these meetings and supporting the work that's already being done. We also want to, in our next cycle, connect to these groups and identify the public health approaches that are already going on and the data and the metrics that they are already collecting, and use that to drive the CHIP forward. So I think in the past, we have not always made those channels and those connections clear between what's going on at the Health Equity Task Force and what data is being collected at the CHIP level. And that's something we want to be more intentional about as we move forward. So my final slide, you have a visual in front of you on your table, but also a visual up here to help us imagine what this CHIP ecosystem should look like and how it should function. Disclaimer, if you don't see your group on the image, it's not because I forgot you or we didn't know you exist. It's we tried to put like all 50 partner groups on this slide, we couldn't read anything. So we didn't forget you, it's for demonstration purposes only. But as you can see, we definitely want to use these community groups to identify approaches and data, feed them up into the CHIP subcommittee and the CHIP document for the next 3 years. And if you notice in that like blue bubble up there, it says LCPH and facilitating partners. It is our commitment and our goal to roll up our sleeves and really make sure the connections from grassroots level to CHIP document are clear and consistent, because we could be doing all the work and collecting all the data, but we all know that that doesn't just automatically or magically appear inside of our CHIP document. It takes a lot of intentional work to make sure that whatever's happening at the grassroots level is, once again, showing up in the CHIP document and driving the CHIP document. So I know that it's hard to go to all these collaboratives and go to all these groups, but we're hoping with this more intentional approach, these slight adjustments to how we're operating, we can prevent that meeting burnout and really start pulling in the same direction. So before questions, and we're ending early, I can't believe it. I'll just end with this, with my microphone close to my mouth. The community health assessment and the data are here to help us drive our decision making. But ultimately, the goal is that in the next 3 years, the CHIP really becomes the North Star for public health action in Lorain County. So with that, any questions? Erin, are you our facilitator of questions?